market. We should take it seriously. We should experiment with it. Besides increase in uric acid, it has got also effect because it works on oats. So it is an oxidase inhibitor. So it also has got slight effect on hemoglobin. It brings down hemoglobin. It pushes creatinine slightly high. So when you're treating a person with bempedoic acid plus ezetimibe, perhaps is a better combination, you must watch it out. If you know your enemy, then it is easier to handle it. But if you do not know, and if it strikes you in the dark, then it becomes more difficult. And all the army guys will, of course, agree with me on that. So it was an excellent talk, very well moderated, and full marks to the speaker, who, in spite of the problems he encountered with all the googlies, he performed very well. Thank you.
Thank you, sir. Professor Fawad Farooq is not here, so I'll ask Professor Dr. Abdul Hamid Siddiqui. Please, your comments on today's session.
Yes, thank you very much. Excellent talk, very comprehensive by Dr. Farahe, and just pointing to the scenery that James was sitting on, I just felt like take my driver and hit a drive. Anyway, I'm just I would like to further reiterate the point that Professor Hafizullah has already narrated, that in our setting, beside intensifying to get the LDL target in range according to the categories of patient, whether they are very high risk or moderate risk, whatever. I think besides the statins and azacitidine combination, if we're not able to achieve, then we have this bempedoic acid available in Pakistan. And this is the next logical combination in our setup from the point of view of the cost that we cannot, that our patient cannot afford as far as these PCS9 inhibitors or the inclisiran is required. So it is very difficult for our poor patient to afford these two very novel therapies, although we know that they reduce the LDL cholesterol more than 50%. They are very effective, but still in our setup, if we want to achieve bring the patient LDL to the target range, and then this combination really suits it. And I think with more and more patients, with relatively safe to use them, except already point mentioned regarding acute gout and anemia that Professor Hafizullah mentioned. That seems to be a logical combination for our patient to achieve the LDL targets. This is from my side.
Thank you, sir. Thank you for your comments. I would like to invite Dr. Hamza Azargori for his output.
Thank you very much, Dr. Qurban. It was a wonderful session by Dr. Ali Farahe. I think he has covered all the bases pretty well, and brilliant moderation from you as always. And I think it's such an august house that we've got, everyone is there, and we were having some interesting discussion in between. And I think I totally agree with Professor Suhail Aziz and Professor Hafizullah when we were having this discussion that, in terms of numbers, we always need to know the numbers. This is what I tell my patients also, because in order to know the numbers, we have to do the drills. But when we look at our patient categories and the kind of patients that come to us, they're coming from, all sorts of groups, whether it's the socioeconomic groups and the kind of understanding they have. Many times we see these patients coming back to us, and even if they've had ACS, the numbers are not optimized. And I think the reason for that is when we look back, this all started in 2013 with ACC recommendations. They came up with cardiovascular risk stratification in their guidelines. And then down the line, this whole thing evolved. We had the ASCVD guidelines and the scoring systems. Similarly, ESC had their SCORE, SCORE score system. But how many of us are actually implementing those score systems in our practices, be it primary prevention or even the secondary prevention? And then how many of us are actually taking care of those numbers? So yes, we know that for these high risk to very high risk groups, we need to reduce the numbers. and they have to be brought down by 50% when we use high intensity statins. But at the same time, the number as low, which was previously 70, now it's 55. But then I think as low as possible, we have data for that as well. So I think this is the screening and the screening tools, the implementation in our clinics, which is important. And there's this other aspect, I think the panel is going to throw some light on that as well, that when we talk about the side effects, how many side effects do we see in our patients, in our category? Because I think it's a misconception. It's a myth that in population, which is South Asian, we have more of these myalgias and myositis and ALTs going haywire when we use high intensity statins. The fact is, statins are still underdosed and underutilized in our part of the world. And I think this is where we have to buckle up and maybe make the most of these guidelines. And with these ezetimibe and these combination therapies, bempedoic acid is there. There's a lot for us to now play with and hit those numbers, and I think do the best that we can. So thank you very much once again for having me.
Thank you, Dr. Hamza. And I would like to invite Dr. Talha bin Nazir for his comments regarding this webinar.
Thank you, Qurban. Dr. Ali, wonderful here. I think it was a very good talk with the challenges you had. It's wonderful to be here with all senior colleagues. So much has already been said, but just to echo what our senior colleagues have already mentioned, having a holistic approach is very important to reduction in the true sense of these clinical events. Secondly, it's improving the attitude of patients, not only towards life, but their own health included, in order to reduce the, obviously, clinical events. Where the statins come, I think already said, use them as much as possible. I think there is an overhype about the side effects of statins. I think we're dehydrated, we're deficient in vitamin, minerals, vitamin D is deficient, all the factors already mentioned. If they're addressed to, I personally think even the myalgias, they begin to settle in. That little bit of counseling that you do for a patient should actually suffice, and it really gives a lot of reassurance and improved adherence. Already mentioned by Jim Sohail about the, it's about the cholesterol burden, and it's very important persistence and perseverance of maintaining the doses and having that consistency and taking these medications and trying to achieve the targets that have been set out with the evidence. Obviously, targets can vary slightly, but general trends need to be taken into account. The other thing I would just like to bring, I'd just like to highlight, sometimes patients are wondering, people are wondering, what do we do with chronic kidney disease? That was just not mentioned, but maybe my personal opinion would be to go for a atorvastatin or a reduced dose of maybe rosuvastatin, but where required, you can use other drugs as well. And no doubt, it's very good to have an armamentarium. Bempedoic acid is there. Eventually, PCSK9 inhibitors would be there, but obviously the financial challenges are needing to be addressed. But if we I need to signpost familial homozygous hypercholesterolemia, which comes with very high, levels, and it's usually seen in the younger age group. I'm sure there are patients out there, they need to be addressed, and bempedoic acid and PCSK9, they won't be working. So we will need to rely on statins and all of the other things as well at the same time. Finally, it's not only about cholesterol, it's about the calories you take in, the calories you burn. Exercise you can't ignore. The quality of the calories you can't ignore. Anabolic hormone involvement, such as insulin, you can't ignore. So one has to have this whole holistic approach. And once this is done, I'm sure we can actually achieve the endpoints, but it requires a great effort and a very consistent effort from the clinical fraternity, from the patient sides, from the community public health, from the media, from the government. But with this, thank you very much. It was very entertaining, and it was very nice to be amongst you all. And thank you once again, Dr. Ali, for this wonderful talk.
Thank you, Dr. Talha. With that, I would like to close this first webinar of the Cardio Web Series 2025, brought to you by the Pakistan Cardiac Society, hosted by the Rawalpindi chapter. It was a superb talk by Dr. Ali, and I personally learned a lot, and I think we all did. Thank you very much to everybody who took part. Thank you to our panelists, and thank you to all of the attendees. With that, best wishes and salams to all. Allah Hafiz.
Thank you.
Thank you, everybody.